Okay, why don't we get started? So, our guest for today is Dr. Chhaya Makhija, and it's going to be quite a fun and interesting conversation and definitely very informative. If you're not already a member of the Longevity Circle, please consider joining it. It's free, and there are lots of fun, interesting, useful conversations like this. You just type in the URL or scan the QR code. Our guest for next week is Dr. Vijaya Parmeshwaran. She has already been on the show once before. This was about 6 months back, and she's a Stanford trained dietitian, clinical dietitian, with a very specific focus on South Asians. And as some of you might remember, she was my first dietitian when I was diagnosed with heart disease. And so she always has a very insightful and useful way of thinking about things. And the topic for next week is going to be cooking oils, because this is a topic that's always has a ton of questions around it. So that's for next week. But for today, our guest is someone that I've been very, very excited about speaking to. It's Chhaya, and her bio is on the screen. But more than anything else, I posted in the group my personal interaction with Chhaya have been very fascinating, because Chhaya is not only a very well-respected doctor and all of that, but also, as importantly, she is someone who has done great work in the community. She spends a lot of her time doing free community work, and that is something that the fact that she makes time for it in the midst of her busy schedule is always very, very fascinating. And so I think welcome to the community, and I'd love to pick your brains on a number of different topics.
Thank you, Nikhil. That's very generous and kind words that you're sharing. I'll only say that, the inspiration, one of the largest inspiration has been my father for what you just described. So I'll give credit to him.
Yeah, I think we all need that inspirational figure. And usually for many of us, it's our parents, but it could also be others. And so on that note, actually, Chhaya, the first question I wanted to ask you was, you graduated from one of the top medical schools in India. You worked at some of the top healthcare systems in the US, and then you gave it all up to go down the path you've been going down when you had no guarantees of anything. And you spent so much time doing all of this work with the people in your community that you did for free. What made you go down this path?
Lovely question. I don't have like a one single answer for it, but it's a lot of life's experiences. I'm 45 now. I made this decision at age 4. One thing was, I grew up seeing my grandma with diabetes. We still don't know if she had type 1 or type 2 diabetes. This was in Pune. And I used to just go around, to the hospital, seeing her inject insulin. And by the time I was 9, I saw her go to forefoot amputation and then midfoot amputation, above knee amputation, and then, passed away within a very short period of time after that. And it just intrigued me. At age 9, I really didn't know what I could do, but it just sits in your memory somewhere. And then came my father's diagnosis of multiple myeloma while I just had moved to United States after getting married, which was 2004. So I was 24 at that time. The education was another 10 years because that takes a long course in medicine. And then it's the usual thing that you decide to get employed or work with a practice, which technically could be a dream practice because you're serving patients. But over that time, like 15 years of going back and forth to India and witnessing my father's journey on how, the Eastern type of medicine, how your spiritual connection, how the positive mindset, despite going through oncology treatment, is so crucial in recovery. It's so crucial when we talk about longevity or health span. It's so crucial to have the best quality of life. And that was also being ingrained in me without realizing for those 15 years. And 2019, when he passed away very peacefully, I had a big surgery done. This was also a surprise to me. And the back and forth, being as a patient in healthcare system sucked. Now, this was me being a physician and me being a vegetarian, and my gastroenterologist telling me, oh, you're a vegetarian, you're good with your fiber intake, you're good with your exercise, nothing else can be done. But, self-research and you're all inquisitive that how I could better led me to understanding or the science behind, plant-based nutrition or exercise, acupuncture, mindfulness. And that led me to decide that this is what I need to bring about to my patients. But so I wasn't unhappy in traditional care, but there was a large gap in traditional care, which is only management, right? You only see an endocrinologist if your diabetes A1C is 15% or greater. Before that, you can't see an endocrinologist. There was a filter. You can only see an endocrinologist if you have severe osteoporosis. So what about osteopenia? What about, if you already have risk factors? So the traditional healthcare system had these filters that you cannot see that specialist until you are in that, complex diagnosis phase where many of the times you can reverse it completely. So I took a chance on myself after a lot of research, by the way. So a lot of doors were closed at me that this doesn't exist. You can't just practice. You won't get paid for it. We can't support you. We'll send you patients, but that's not the right way to practice because medicine will not be a business then. Then you'll be doing social service. So that's why I took a chance on myself in 2020. And decided to start like a direct care model to practice endocrinology, but also integrated it with a lot of prevention and lifestyle interventions and one-on-one time, which my father had mentioned to me that just the way you've been with me, despite traveling from US back and forth, just the way you've communicated with the oncologist or even Ayurvedic doctors, even homeopathic doctors, just to justify where is the science and where is the wisdom. Do that with your patients.
Wow.
So that's the life I'm living now.
Yeah, and you're living it amazingly well. There are a number of different points, Chhaya, you made that I think I want to just double click on. One is the power of people feeling like you're there in front of them. They are not just a number, they're just not a record, they are an actual human being. And the fact that you could spend time with your dad, that mattered so much.
Absolutely.
And I can speak from first-hand experience. I would go back for my mom's chemotherapy every 2 weeks. And just the fact that I was there to hold her hand made her feel better and made me feel better. And somehow that is with the way healthcare is evolving everywhere, definitely in the US, but I think it's also beginning to happen in India.
Yeah.
That doctors are so busy. Even if they would like to hold your hand, they can't. It's you got 10 minutes, you say what you have to say, you move on. And that I think takes away at least half the value of the care that the doctor can provide.
Yeah.
Point that I really wanted to highlight in what you said. And the second point is the power of purpose, the power of community, because it's not just one person, right? Like I just could never convince my mom to come here to get treatment, even though I knew she would get better treatment here because her friends were there.
Yes.
At her home. And that is something that cannot be underestimated, right?
Yes, that helps you heal. And that's the largest anchor for the quality of life.
Yeah.
Absolutely.
Yeah. And so now you make this leap, and there are people telling you, well, this is not going to work out. You're making a silly decision. I'm sure you heard all the naysayers say all of that. And yet you stuck to this, and it has not been an easy journey for the first few years, right? What was it always the fact that you kept thinking, well, why am I doing this? Was it the purpose that kept you on track? What kept you on track?
So, when we talk about naysayers, it's also, even if you have a few supporters around you, that makes it happen. So it is a lot of kudos to, my close family, my spouse. He's my rock. And, the purpose of the why that you mentioned, and always the inner voice that, are you happy? Can you go to sleep well every night? And the answer was always yes. So keep striving. Yes, there were times that I was like, this is not happening. I cannot make this into per se a business or, entrepreneurial journey. But, after 1 year, the perspective shifted that this is not about me. It is not about me practicing endocrinology. This is not about me sharing my knowledge or trying to take care of people or change their lives. Is it about them? It's everything is about them, what they need, and I'm here. And that's where, the community events, like just being a part of it, without having any expectations, made a gradual shift in where we are today. And I'm still learning.
Yeah. I mean, I think what you just said is so profound, which is it's not about me.
Yeah.
And just earlier today, I got a message from another friend, a doctor friend, and she said, because we are working on something similar, the way you and us are working, Chhaya, and she said she ended her statement, her message with, "In service of something bigger than us."
Mm.
Right? And I just thought, wow, that actually captures why we do what we do, right?
Very true.
So now getting into the into hormones. I mean, this is a topic. I don't think the word hormones have been used as much in the first 40 years of my life as I've heard them in the last 15. Uh, and now general awareness has gone up that hormones are something important. Not everybody is clear why they're important, what they do, but they understand that there is something that they do that impacts everything about our health. And so maybe it will be useful, Chhaya, for the audience to hear from the basics, what are hormones and how do they function and how do they help us?
Yeah, absolutely. Great question, because it simplifies, what we'll discuss later. So endocrinology is study of hormones, and that's why, Nikhil is probably asking this question about breaking it down. They're chemical messengers, as simple as that. And one simple thing to remember is that our cells cross talk with each other. So there is a silent communication between trillions of our cells, and they're talking to each other. And that's why we are able to perform, that's why we're able to function. So hormones, being that chemical messengers, are not just estrogen, progesterone, and testosterone. It's a plethora of chemical substances that are actually helping you to be awake. They're actually helping your heartbeat and so on. So, our powerhouse for this hormonal control is in our brain, which is called hypothalamus, very tiny area, and that sends signals to something called as pituitary. So if this is the video, just behind the eyebrow, we have something called as pituitary gland, which is a pea-sized gland, literally pea-size, and that's the powerhouse for most of our essential hormones, and that's residing at the base of the brain. Now, hypothalamus and pituitary are actually sending signals below the neck so that every gland which is producing hormone is functioning. And I'll just walk through that before, what hormones they're releasing. So there is thyroid in your neck. There is parathyroid in your neck. Those are hormonal glands. There is liver, which is actually also a hormone producing gland. There is pancreas on your left side, back of your stomach, which is the factory for your insulin, for something called as glucagon. And below it, sitting on top of your kidneys, are very essential glands called adrenal glands. They're paper thin, very tiny. We have two of them sitting on the adrenal glands. which are also producing a plethora of hormones, and then comes ovaries and testicles. Now, these are just the basic hormones, by the way. Many of us are aware of GLP-1. They're actually our own hormones coming from the gut. We have something called as leptin, ghrelin, which maintains our appetite. Our bones produce hormones. Kidneys produce these chemical messengers. Heart produces chemical messengers. So there is a crosstalk going on. And what is that crosstalk? So hypothalamus, which is your powerhouse, is sending a signal to your pituitary, and it governs very important hormones. One is your stress hormone. So it's sending signals to your adrenal gland, which is releasing cortisol or stress hormone, that, hey, this person needs so much at this particular interval, and it follows a circadian rhythm, that is day and night rhythm. Then it produces growth hormone, which is the most essential one during your childhood, adolescent, puberty, and then young adulthood. It's sending signals to your liver that, hey, produce enough, something called as IGF, insulin growth factor, so that our height, weight, body composition, muscle growth is happening at the right time, and it peaks around age 18 to 20. The third essential one that it does is gonadal hormones. So in females, that hypothalamus pituitary is sending signals, that is, it's producing hormones to stimulate ovaries, to stimulate testicles, to produce estrogen, progesterone in females, and testosterone in males from the testicles. But it's also sending signals for follicle development, that is in females, egg development, and it's sending signals in the testicles to make some sperm. That's called spermatogenesis. Now, I haven't even covered 50% of the hormonal signals here. So that's very essential to remember. There is prolactin, which is a milk-producing hormone. Normal physiology, when a female is pregnant, planning to nurse, that's where that prolactin and oxytocin levels become important, coming from pituitary. Another essential hormone is for salt and water balance. So that's also coming from the pituitary gland. And we have another hormone called aldosterone, which is coming from your adrenal gland, the gland sitting on top of the kidneys. So your salt and water balance is also maintained by hormones. It's not just, drinking your electrolytes, right? And then we have the thyroid, which is also an important life-sustaining hormone. Again, hypothalamus sending signals to pituitary, pituitary sending signals to the thyroid. And now these hormones below the neck, right, so thyroid, adrenal glands, testicles, ovaries, are producing the active form of the hormone. When I say active, meaning they are the ones who are bringing about an action. So thyroid hormone is controlling your metabolism. And metabolism, in simple words, is how's your engine running? At what speed? How's your heart running? At what speed? So it controls your heart rate, controls your breathing, your oxygenation, your salt and water balance, your energy levels, your weight. It's a contributing hormone. There's something called as parathyroid hormone sitting behind the thyroid, which regulates your calcium, vitamin D, and bone remodeling. That is, how often or how balanced your bone formation and bone breakdown is. All right, so if you're tired, I am not yet, because I haven't covered anything underneath the neck yet. So let's walk through that. I'll cross the heart and lungs, because those are other more nuanced hormones. And liver, we talked about the insulin growth factor, which is helping you with that growth or the height and the body composition aspect of your health. Your adrenal glands become also very important because one is aldosterone, that is salt and water balance. It's producing androgens. Androgens are male hormones, which are also produced in females. So we have something called as DHEAS and testosterone, which females are also producing from the adrenal glands. And then comes cortisol. Thyroid is one of the most essential ones for our life. We cannot sustain our lives without it. Next is cortisol. We cannot sustain our lives without cortisol or stress hormone. Stress hormone doesn't mean that it is only supposed to be produced when you're stressed, but it's actually essential for our daily function, and that's why we cannot sustain life without it. The last part of adrenal gland is your adrenaline. So there is sympathetic nervous system or adrenaline, you call it as adrenaline rush, or when you're exercising, you feel the adrenaline, but that's where that important hormone is produced. There are other places too where adrenaline and noradrenaline is manufactured or synthesized. Testicles and ovaries, I just touched base, so you know what they're producing, but there's something called as AMH also, which is coming from the ovaries, and inhibin from the testicles, which is also another hormone. Insulin, that's the third essential one that we cannot sustain our life. So thyroid, cortisol, and insulin. Insulin is coming from the pancreas, and we need to respect that hormone too, because too much of it or too little of it is disease. So any hormone, excess amount of it or deficient or inadequate, is going to lead to an endocrine disease or many other metabolic issues. The reason endocrinology is a part of diabetes is because of this reason. Insulin is a hormone, and that is directly related to pre-diabetes, type 2 diabetes, type 1 diabetes, gestational diabetes. There are lots of neuroendocrine tumors, which I won't touch base on, which are also hormone producing. And then comes bone. So your vitamin D, calcium. Vitamin D is a hormone. It's not a vitamin. So vitamin D, calcium, phosphorus, magnesium, how is the bone remodeling happening, is also part of hormonal study or education, or that piece of field of medicine. But if our hormones are not regulated, all the ones that I enumerated will have positive or negative impacts on the bone health or bone metabolism.
Wow.
I think
There is so much to dissect there. But maybe, Chhaya, what would be helpful is, let me pick a couple of hormones, some of the bigger ones, right, that you mentioned, the three big ones: thyroid, cortisol, insulin. And of course, like you said, every hormone plays an important role, right? If our bone health is not good, we are in trouble. But let's start with these three, because they're also maybe the three that are spoken about the most. If I were to ask most people, name three hormones, I would imagine those are the three that would get picked, because that's sort of in the news for various reasons. And if you can, and while you've sort of touched upon it, if you could just sort of one by one do a double click on what are the things that we experience if the thyroid hormone is too high, too low. Similarly for cortisol, high or low, and insulin, high or low, because those are things that I think the audience will be able to relate to, saying, yeah, you know what, that seems to be something I experience. So maybe now it gives me some light.
Sure. So we can touch base on thyroid first, because that would be very clear. Now, thyroid disorder is the most common endocrine disorder that we see in humans, or a hormonal disorder that we see in human beings. And women are more affected with a thyroid disorder as compared to men. The third thing is also important to know that many endocrine disorders, that is hormonal disorders, can be autoimmune. And autoimmune, I'm pretty sure you've touched that in your previous podcast episodes, but it's not self-inflicted, but our body tends to produce these attackers or proteins which can target specific receptors and not let a particular gland work effectively, or it may work in a inappropriate manner to release excess amount of the hormone. So that's thyroid disorders. So thyroid disorders are the most common, and the most common etiology or reason is autoimmune in these scenarios. There is a spectrum. So, if I had a pen, there's a balance, and if you get labs done, they'll usually give you a range. This is normal. And then if you fall in the extremes, then there is something called as underactive or inadequate thyroid hormone, or excess, that is hyperthyroidism, or overactive thyroid. Now, what needs to be understood is this is gray zone. So there is normal, but by the time I'm reaching to hyper, or by the time I'm reaching to hypo, there is something called a subclinical disease. That is, it's not 100% there yet, but it's progressing, or someone's staying there. So all of us tend to hover in that spectrum, and that's why symptoms and your clinical correlation is very important before you just rely on the symptoms that I'm going to share. Okay, so underactive or hypothyroidism is again now amongst hyper and hypo, the most common autoimmune condition in humans. Affected, again, females are more affected than men. Like I mentioned, thyroid controls your engine. So if there is inadequate thyroid hormone, my engine is going to run slow. And what that means is tiredness, but it's not very non-specific. There are certain ways that I'm dragging myself, or it is every day, and there is no circadian rhythm to it. I'm just tired 24/7. There is a gradual weight gain. Now, the other aspects are if the person has extremes of hypothyroidism, they can have swelling, water retention, because it regulates salt and water balance. In children, when they have this condition, that's more obvious that their performance worsens. So your cognitive function can get affected. In adolescents and in kids, it's more obvious, and in elderly for hypothyroidism. The others are, slowing down of the heart rate, or the deconditioning. That is, you were active, but now you're more short of breath as compared to what you were performing in the past. So your fitness. There could be some muscle loss if it's, again, inadequate and it's still not being treated. So fatigue, weight gain, if you see that, first thing is to rule out hypothyroidism or subclinical disease. Now, many of the patients may not have these symptoms, especially my men. And this is also seen in literature that they'll be significantly hypothyroid, but because men don't complain about their symptoms as such, they don't care about the weight gain as such, and the fatigue, they'll just push through it. So that's why, other symptoms in those scenarios are very important is erectile dysfunction or loss of morning erections. So these are all part of, hypothyroid symptoms, but how we dissect it based on what age group we're also dealing with. And then comes a good phase in women. So preconception period, pregnancy, postpartum, they're at a higher risk of developing autoimmune thyroid disorder. So those are peak times that you want to check these levels, or as soon as you have symptoms, or even if you don't have symptoms, make sure there is screening done annually for thyroid hormone. Perimenopause, menopause is another phase of life in women where the thyroid hormone disorders, which are autoimmune, the risk is higher. The incidence goes up again. So again, annual screening versus if you have symptoms, definitely do it sooner. So that was about thyroid. Now,
I can ask a question about thyroid specifically before we move to the next one.
yes.
How does one tell? Because one of the things I keep hearing is, as we get older, sometimes we just assign it to, oh, this is what happens when you get older. But that's not necessarily true. It's possible, even when you get older, to still not have any of these things. So usually it is not just about getting older. It's also about the fact that something is going off track.
Correct.
Is the best way to figure out that it is a real thyroid issue? Number one, get your tests done regularly. And number two, when you have symptoms, talk to a specialist.
Both are right answers. So in women, you want to have your thyroid hormone, at least your TSH and free T4, not just TSH, minimal in your annual screening. Because it's the most common endocrine disorder, and you'll be surprised when you get into the family history, there will be these autoimmune phenomena occurring in many of these individuals. So for women, you want to get the annual screening. For men, it's usually when you have symptoms. But like I said, you want to break down the symptoms, not just weight gain and fatigue in men. There is more to that with hypothyroid. I haven't crossed hyperthyroidism, because if individual has those symptoms, then you want to get those checked when you have symptoms. But in general, for women, get it as an annual screening. For men, yes, when you have symptoms, versus we haven't gone into the aspect of metabolic health, but when you're looking at obesity, weight gain, or fatigue, or the erectile dysfunction, any of those scenarios, you have to make sure that you're getting the thyroid tested for men.
And another question, because you have referred to autoimmune, right?
Yeah.
This is a topic that is also becoming more and more common. Is it becoming more common because it's becoming a bigger issue than it was in the past, or is it because it was always an issue, it was just never diagnosed as autoimmune?
So in the endocrinology world, Nikhil, we always had this, background of because endocrine conditions, autoimmune is the most common cause. And we had quite a lot of antibody testing available at that time as well. They were more expensive and they were not needed to make a diagnosis because it's very obvious. If you have hypothyroidism, 95% of the cases are autoimmune. So what's the utility in getting an expensive, antibody testing when you already have made the clinical diagnosis and you know what the treatment is? So in autoimmune world, it's not something new with the etiology or the testing. But in the rheumatology world or gastroenterology world, allergy, where we have more and more plethora of autoimmune conditions being diagnosed and more antibody testing being available, there is a rising incidence of these conditions because of several other factors other than family history, other than having having a history of autoimmune conditions in your personal history or family history. It's the environmental exposure, endocrine disruptors, which are leading to these conditions. But in the endocrine world, we've always had autoimmune as the most common diagnosis.
Yeah. So I don't want to interrupt your flow, but afterwards I want to come back, Chhaya, to what can be done about autoimmune. And maybe that's not the scope of this conversation, because that's a whole topic in itself. But because we've been talking about autoimmune and how many disruptors that are there around us in our lifestyle today, right? Amount of plastic and all of that. That's a whole topic. But maybe if we have time, we'll come back to it. But move on, continue with the approach you were stating for each of the big hormones.
Sure. So we covered hypothyroidism, and hyperthyroidism is going to be short, hyper, Hyper, overactive, too much. Also, the most common condition is autoimmune, Graves' disease, but some individuals may have nodules inside their thyroid, where we just do a bedside ultrasound to look at those. Or it could be the entire gland just producing, misbehaving, or becoming a rebellious teenager and producing too much thyroid hormone. So the opposites, there's overactivity, palpitations, tremors, anxiety, sweating. These individuals can also have fatigue, weight loss, diarrhea or loose stools. It's called hyperdefecation. So everything is running too fast. Very, very important to get a thyroid test done in these scenarios. In the cardiac world, that's one of the common reasons to get it done if they have arrhythmias or irregular heartbeat. If you have any of these symptoms, you get it done sooner with your testing. But like we talked about screening, it follows the same pattern for men and women. We should switch
I
to.
have to measure it later. Machine is misbehaving. It's
Samira, can
not
you?
starting.
Hello, Samira, can you go on mute, please?
Thank you. Cortisol is a very essential one. Now, thyroid does not have much of a circadian rhythm, so it's existent throughout. You can get your labs done anytime. It'll be approximately the same. So there is no fasting period for getting a thyroid test. But on the other hand, cortisol follows a very amazing diurnal rhythm. That is, it follows your sleep and wake pattern to increase and reduce the secretions or production from your adrenal glands. And it is an essential hormone because it's also involved in like a fight and flight response, right? And that's why it's called as a stress hormone. There is a lot of influencer terminology being used, that is, my cortisol is imbalanced, or I have adrenal fatigue, that is, too much cortisol. But I just wanted to bring about the clarity here that if we are living our lives with fight response every few seconds, that is, get up in the morning and you're just trying to get some coffee, get your kids out, you're watching TV and you're watching all the bad news, and that's influencing you. That's already raising your cortisol more than what it is supposed to be physiologically. So we are in this fight and flight response day in and day out. And if our routine is not as disciplined as we would want to, eating patterns are not consistent, sleep time is not good, doom scrolling is ongoing before bedtime, it all impairs our cortisol secretion. And that will not necessarily lead to a pathology, that is not necessarily lead to a tumor producing cortisol, but it just disrupts your circadian rhythm. So that's the most common way of describing an imbalance. So it is our lifestyle and how we perceive things, which is affecting our cortisol, not the other way around. And now comes, what are these diseases? So autoimmune condition or autoimmune cause affecting our adrenal glands can cause adrenal insufficiency or low cortisol, and that is appropriately, it needs to be diagnosed and treated because it's life-threatening. Or if someone's had, any adrenal tumors or tuberculosis, HIV affecting the adrenal gland, it can lead to adrenal insufficiency. Or if someone's had some problem with hypothalamus pituitary tumors there, it can impact the signaling, lead to adrenal insufficiency. So low cortisol is hypocortisolemia, adrenal insufficiency, same thing, fatigue. It'll have weight loss. You're not able to function appropriately, mental cognition. So everything is slowing down. So imagine I cannot respond to fight and flight situation. It's all low. It's all suppressed. Too much cortisol is hypercortisolemia, usually because of steroids that an individual is taking for some condition, or they have an adrenal tumor. That's a real excess cortisol. It will lead to insulin resistance, significant hyperglycemia, excess sugar, type 2 diabetes, high blood pressure. So too much cortisol is going to just ramp up the metabolism in such a way where we have metabolic diseases, obesity, weight gain. And these are related to adrenal tumors, pituitary tumors as well. So the most common is that cortisol imbalance that I mentioned to you, which is fixable by us, noticing it in terms of our lifestyle. You can get labs done, but it's not going to be helpful. It's more of a clinical and symptomatic assessment.
And Chhaya, I just want to sort of double click on a point you made, which is cortisol does follow the circadian rhythm. And so, though, like you said, it's often called a stress hormone, there are times of the day, for example, right before you wake up, your cortisol level goes up to actually wake you up, to make you alert, to get you ready for the day. So there are certain times when it needs to go up. But
Yes.
There are times when it should not be going up, especially as the day comes to an end. Your cortisol level should go down. You should be more relaxed. And yet, if you're dealing with stress at work, you were late to pick up your kid, all these things can actually start again increasing your cortisol levels. And that's when you have a harder time going to sleep and so on, right?
Absolutely right. So 4 a.m. and 7 a.m. is more physiological peaks, and that's when we get labs done, like between 7 and 9 a.m. to look at your peak cortisol. But when you look at these disruptions in our routine, especially tech workers or night shifts, graveyard shifts, and when we are looking at their continuous glucose monitors, right? The blood sugar is higher during those phases because of the stress hormone, because of the cortisol. So, these are great tools to identify that, my response to stress is still in my control, and I can see how it's impacting my blood sugar. So absolutely, if we are disrupting the circadian rhythm for cortisol, it will impact our metabolic health.
Yeah, and I'm so glad you brought up that point, Chhaya, because, a lot of people have started putting on continuous glucose monitors, and the usual approach is to use it to figure out which foods are causing a spike. And yet there are times when you have the exact same meal and it causes very different levels of spike because you didn't sleep well the earlier night. And so the fact is that while we focus on glucose, and there is good reason to focus on glucose, it's important to keep in mind the point you just made, and that is that cortisol can also cause glucose levels to go up, not just food.
Absolutely. You know, there is a nice handout that we share or add in our diabetes education, 42 factors that can affect glucose levels. I can definitely share that with you also, but it is what this is talking about. You know, even menstrual cycles, even, you know, your like you talked about the sleep discrepancy, even proteins and fats taken in what ways can affect the blood glucose. And then, of course, you know, stressors, injuries, pain. So many other things impact our glucose levels.
Right. All right. And then we have on to insulin next.
Correct. Yeah. So that's going to be the majority of our discussion, I feel, because it impacts a lot more in terms of the diseases that it can cause, and it's not, you know, simple black and white. So insulin is the third essential hormone, and it's coming from something called as beta cells of pancreas. Again, on the left side of your abdomen. And it is, you know, there are other cells in the pancreas, but we just focus on insulin. But it is the big boss who's regulating how your glucose levels should be day in and day out. So without insulin, our glucose cannot be used as a fuel. And we all know that glucose is the main fuel for our cells, for our engine. So without insulin, the glucose cannot enter inside your engine or inside your cell to actually be utilized as fuel. And that's why insulin deficiency or inadequacy will lead to diabetes or high blood glucose because there's too much glucose circulating in the blood. Now, to break down what is that imbalance or what are the disorders, so I won't talk about type 1 diabetes because that is also autoimmune. You know, the body is not capable enough to produce any more of insulin because of the beta cell death, and those individuals need insulin multiple times a day or insulin pump lifelong. But the most common scenarios that we see is pre-diabetes, which is 1 in 3 individuals with diabetes, at least the most recent stats in United States of America, and type 2 diabetes. But even more is undiagnosed insulin resistance. I don't know if your audience or if you've heard about pre-diabetes, which is very, very important to capture. And these are all legit, you know, studies and interventions that we've had over the years to identify. So our body, first of all, we need to know that we have great metabolic resilience, and our body has a lot of capacity to adapt to stressful situations. And that's why we don't recognize diseases early on. And that's why we have tools to figure out how can we identify things early on. Right? So knowing that insulin regulates glucose, it's also an anabolic hormone. So it has lots of other effects. But let's focus on glucose for our audience, because that's going to really connect with a lot of metabolic dysfunction as well. Where do you want me to start? So I could tell you about, you know, the disorders, insulin resistance, but what would be the most important for your audience here in terms of describing, or just focus on South Asians?
I think I think focusing on South Asians and with a specific sort of double click on how it manifests itself. You know, for example, and I'll give you a couple of examples that I discussed a lot, because then you can provide the root cause behind it. You know, you made this comment that insulin determines how glucose gets used as a fuel, right? But it also, and for that same reason, it's also why, even though you might have a lot of fat storage, you can't really use that fat when you want it, because insulin is always too high. That's one point, right? The second point that we discuss a lot in the community is people don't become diabetic overnight. It's happened over 10-15 years. And so many of these signs are there. The insulin resistance is there. But we look at our HbA1c, oh, it's fine. So that means everything is great. But it's not. And so I think some sort of context around that would be helpful, Chhaya.
Yeah, absolutely. So one thing to remember is, if you break it down, South Asians, okay, South Asians are a whole bulk of countries, but let's talk about India, Pakistan, Bangladesh, Sri Lanka, Nepal. We have a higher tendency to have insulin resistance, and the double whammy is that our beta cell reserve is lower than the other ethnicities. And we just touched based on beta cell is what's in the pancreas, which is producing insulin, right? So most of us tend to have these two as more of an inheritance or the genetic patterns. And this is a lot to do with epidemiology and how, how the generations have evolved. So it wouldn't be surprising that most of us in this audience have some or the other relationship where they have type 2 diabetes or pre-diabetes or undiagnosed insulin resistance. Keeping that in perspective, young adulthood, right? So now we are getting exposed to the environment. So we know our genetic contribution or ethnicity contribution, and now comes the environmental exposure or the environmental factors, and that is in our control. So, when we talk about 50%, 50%, think about 50% is fine. I inherited, or fine, I'm, with this, I belong to this ethnicity and I have this higher risk, but 50% is in your control to modify. Okay, so these are modifiable factors that you can work on. So yes, like you rightfully said that by the time you're getting your hemoglobin A1C, there is type 2 diabetes, but you've lost 50% or more of your beta cell reserve with that diagnosis. So let's rewind and come back to early stages. That is, if you have a family history. If females have, a diagnosis of polycystic ovarian syndrome, if females have diagnosis of gestational diabetes, if you are an adolescent or in childhood, if you're noticing acanthosis nigricans, which are darker lines around the neck, in the front, skin tags, these are all signs of insulin resistance. If you are gaining weight, right, for what reason? One of the most common causes for South Asians is insulin resistance. Now, why is this happening is insulin resistance, because we didn't touch on that, is because I said, our body is really capable of fighting against problems or diseases or imbalance. With that inheritance of the race, of the ethnicity and family history, we have a tendency to just produce more insulin to make our glucose levels normal. In that process, we are also modifying how our cholesterol, how our lipids are being regulated in the liver, and that's impacting it negatively. When you go to your physician or you get your annual screening done, you'll be like, oh, my A1C is good. Maybe my glucose is also good. No one checks insulin, by the way. And, I'm fine. I don't have diabetes. I don't have pre-diabetes. And, I'm good, even though I have risk factors. But if you were a clinician or if you're a person, think about your family history, think about, any of your skin lesions, ask for, I usually do an insulin level, but that could be discussed with your with your clinician about would that be helpful. But the things that you have in control is access to food. You have access to exercise. Even in our endocrinology boards, till date, we always have a question, which cell can utilize glucose without the need of insulin? And the right answer is muscle. Okay, so there you go. So you have the choice of utilizing your own glucose, even if you have insulin resistance, by really contracting those muscles, using them, exercise, movement. The third is, environmental exposures, endocrine disruptors, which are not a major contributor. So processed foods or utensils and plastics, chemicals, they can affect it. They can, but they're probably contributing 1 or 2% of the problem. The fourth thing is, we talked about cortisol. So our discipline, our routine for life, cortisol worsens insulin resistance. So if the cortisol is the imbalance is the diurnal variations, too much of cortisol when it is supposed to be at its trough will lead to insulin resistance. Very poor sleep, undiagnosed sleep apnea, restlessness, worrying about things when we are not trying to seek, some form of mindfulness or seeking support, is all going to contribute to worsening insulin resistance. And this is not just diabetes, it's impairing our cholesterol. Pre-diabetes is a cardiovascular risk factor, meaning it's impacting our heart even before we see a change in the glucose level, right? So if you know your why for your health, that I want to prevent heart disease, I want to prevent stroke, I want to prevent, being dependent on 5, 6, 7 medications and insulin, think about not just the screening, but also what are the lifestyle interventions that I just need to build on, adapt, modify, which is going to help me prevent all these metabolic dysfunctions.
And I think I want to tie what you just said, Chhaya, to some of the things that are discussed often, right? People keep hearing, you must exercise, it's good for you. But using the lens of hormones, right? What you've just explained, now it makes that much more sense as to why it helps. For example, we don't want when we eat a lot of carbs, right? There is a lot of sugar in our bloodstream. We don't want a lot of sugar in our bloodstream or glucose in our bloodstream, because that causes that's not a good thing. It causes diabetes, this and that. But for the same reason, we don't want too much insulin hanging out either in the bloodstream, because it's a growth factor, it's an anabolic steroid, hormone, it actually causes bad things to also grow. It causes good things to grow, but it also causes bad things to grow. But you made the point that one way to get glucose down is to have insulin. One way to get the insulin down is to exercise, because the muscles can pull out the glucose without requiring. And so when someone says exercise, now hopefully it provides the background. Your explanation provides the background as to how you, without requiring insulin, glucose can still be taken out using by the muscles, using through exercise. And so sleeping, we say sleep on time. But now, given your explanation, it becomes clear. If you don't sleep on time, or if you are constantly stressed and you're not sort of meditating, not doing breath work, it's keeping your cortisol levels high. Your cortisol levels remain high, your glucose levels go high. So it all comes down to first principles. Don't do something because someone said, go, meditate or, do strength training. Do it because you understand how the hormones get impacted by those actions. And I think that to me is probably the most critical takeaway, is that what you've provided is first principles explanation and understanding of why we hear all these things we keep hearing: exercise, sleep better, eat better, try to meditate, do breath work. There is a reason behind it.
Yeah. It's easy for us to preach if it wasn't being practiced. I practice it myself. So I have strong family history of type 2 diabetes. I told you about my grandmother. I have my first cousins who were diagnosed with type 2 diabetes at age 25 and 30, have had heart attacks, have, poorly controlled diabetes. They don't get any inspiration from here. But it's not about, like I said, it's about who needs it and who would want it, will take it. But personally, I have to make sure that I practice because I know the why. Right? Yes, there is the family history and the ethnicity that's contributing, but how can I keep my A1C below 5%? How can I make sure that my insulin levels are single digits so that, I don't have insulin resistance? I never exercised until I would say 12, 13 years ago. I mean, walking is fine. That was all. I was always active, but focusing on strength training, learning, getting injuries, but also building on that, right? So your metabolic memory is not just for 3 months, 6 months. Like, keep building on it, because your why, and it's a process of lifelong. So don't think that if I just did something for 1 year, I've prevented everything. But it's a way of living. And you keep modifying it. And trust me, every year you'll just upgrade yourself and optimizing your health.
Yeah. I know we're coming close to time, so I want to quickly go through some questions. How do you differentiate between thyroid disorder versus metabolic syndrome? Because the symptoms seem to overlap.
Sure. If you think about fatigue, we could even have fatigue if we don't sleep well. for nights, right? So differentiating thyroid disorder is very straightforward in terms of getting the right blood test. And like I said, it doesn't have to be fasting. So you're already ruling out or ruling in if there is a thyroid disorder. And metabolic syndrome is a large picture of, insulin resistance, impaired glucose, the triglycerides and HDL, your waist circumference, your visceral fat. You can get a body composition done to look at that. But that's more metabolic panel that you're looking at. But metabolic syndrome will not just cause fatigue and weight gain by itself. You'll also see a lot of biochemical lab abnormalities, which will help you diagnose metabolic syndrome. But thyroid should be very clear. These are the most reliable tests that we have in terms of diagnosis.
So TSH, free T4.
Yeah, and then hyperthyroidism, make sure you get your free T3. The reason free T3 is not always reliable, like in India, it'll always be done. Here, if you order thyroid panel, it's always done. The assays are not very sensitive. So if you have your clinician who can help you interpret it appropriately, then go ahead and get the free T3. But if you don't have the clinician to help you with the interpretation, don't rely on what the lab is telling you. But TSH, free T4, 100% reliable.
Yeah. I mean, I know we had like a list of 12, 13 questions. We went through 3, but I got another 10, 12 on top of the ones we didn't cover. Like, for example, given the point you just made, Chhaya, should one be doing the function health test, right? And others like function health who give you 100 different parameters. Some make a lot of sense, but some others, given the point you just made, need to be interpreted correctly. Otherwise, it can sort of send you down the wrong path, right? But I just want to put that out there. Maybe we have to have a separate conversation just on that. But let me go back to the questions from the community. Could you talk about adolescent pre-diabetes? If it is there any different from the adult version?
Not really. It's just that, our younger and younger generation are being diagnosed with insulin resistance and pre-diabetes. I see only adult patients, but my youngest is 15-year-old with florid type 2 diabetes. It used to be a diagnosis of age 60 and above. So you have to be really aggressive with treating it. Yes, lifestyle, but if you need the support of pharmacological management sooner, you'll save their beta cell reserve and not let them get converted into type 2 diabetes.
Yeah. How do you ensure mitochondrial function remains good, and can it be tested? Can mitochondrial function be tested?
This is like a longevity question. So, you don't have a test to actually say what your mitochondrial function is, but just understand, it's your engine, right? If you're energetic, you're feeling good, you're exercising, you're making sure you're doing all the screenings. If there is a abnormality, lab disorder, metabolic issue, you are fixing that, right? That itself justifies you're taking the ATP, you're utilizing it. But there is no specific diagnostic to tell you this is your mitochondrial function, 100% accurate.
Yeah, I guess, Chhaya, the closest one can say comes to that is like do a VO2 max test.
Sure,
right?
yeah.
That is probably the best test you can do to tell you how well your mitochondria is functioning. Also do other things, but at least it gives you that aspect. You mentioned pre-diabetes. What are the clinical markers of it?
So pre-diabetes has a lot to do with insulin resistance, where your glucose is normal, A1C is normal, but when you go to the lab and get a fasting glucose and fasting insulin, we calculate something called as HOMA-IR, which is an assessment model to look at insulin. But a simple rule for me, for my patients, I don't even calculate that. Look at the insulin level; it should not be in 2 digits if your fasting glucose is normal. Yeah. So that itself suggests hyperinsulinemia, and that's pre-diabetes.
Yeah, and it's one of the things we have spoken about in the past as well, and I'm glad you made that point again, Chhaya, which is fasting insulin does not show up on most panels. It's something you have to explicitly ask for, and it's worth asking for because that's a pretty good. It almost precedes fasting glucose by 5-10 years in terms of showing that you're on the wrong track. Right?
Yeah, if you're in US, you can get a cash pay lab. It's less than $20, even if you're not getting it. And in India, it's easier to get the fasting insulin.
Yeah, exactly. I think Sachin just made a comment. Cortisol levels need to be revamped. These were studied 100 years ago. Now with the advent of electricity and screen, I'm sure the levels and measurements need a change. Even 4 a.m. to 7 p.m. should be revamped. So, but one of the things that Aarti's also mentioned, great session. Please return with more discussion on lifestyle adaptations. And Aarti, we had all these points that we had put together for lifestyle that were supposed to be discussed, but unfortunately or fortunately, it means that we'll have to invite Chhaya back for another session just on that topic.
Yeah, I would love to, but I feel like your platform is built on lifestyle interventions and how to optimize it. And yeah, it's pretty robust. So, I would concur with all of them in terms of preventing these metabolic disorders.
So, I want to, you're seeing a lot of love coming your way, Chhaya, on the screen, but one of the things I want to just make a comment about for everybody on this in the community is that very shortly we are going to be announcing a program where doctors like Chhaya and Dr. Ali Zaidi, who often answers questions on the community, Andrew Talansky, the Tour de France rider who was on the community, we're going to get people like them whose values and approach we at the Longevity Lab, Longevity Circle align with, and we're going to give access to them through one-on-one sessions that we will announce. So if you want to talk to Chhaya in more detail, that's something that we will shortly be announcing in the month of March. So on that note, I think we are well out of time, but we will definitely do one more session. But thank you, Chhaya. It was an excellent session. Just so much to learn, and I'm sure we'll have many, many more such insights from you over the coming conversations.
Yeah, thank you. I love there's this Kedar who's put this as longevity satsang. I love that terminology.
Yeah. So thank you all for staying up. Good day and good night.
Good night and good day. Thank you. Thank you, Nikhil.
Bye, darling.